All right. Before we get going, I'll just say that I have no financial conflicts of interest to disclose. This work is funded by the National Institutes of Health, but the work presented here doesn't represent the NIH or any of our state partners that we're working with here in Tennessee, including the Tennessee Department of Education and TennCare, the state's Medicaid agency. Okay, as most of us are probably aware, child mental health needs in the US are rising. Since 2016, rates of diagnosed anxiety, behavioral and conduct problems, and depression have increased by more than 25% among youth in the US. And that the trajectory of those outcomes, those conditions have only increased since the COVID-19 pandemic. This means that by the age of 18, roughly 40% of all adolescents will experience a mental health condition. In Tennessee, we've undertaken some work to talk to our state partners that work in schools. And this quote is from one of the mental health counselors in a school district in Tennessee. And we got this quote sometime in the middle of the fall semester, so 8 to 10 weeks after school had started. And it says, we've seen a huge increase in students with anxiety and to a debilitating level that they can't function in a regular school setting. In Tennessee, the suicide protocol is called a Form C. And if a student expresses suicidal ideation, a counselor immediately fills out a Form C. We've been in school since August 8th, and we probably already have 22 or 23 of these forms, students that have expressed suicidal ideation. But despite this increasing need, via increased prevalence of mental health conditions, roughly a third to half of adolescents a year don't receive the mental health treatment that they need for a mental health condition. So not only is this a rising problem, but the solution isn't rising at the same rate that the problem is. This is a place where schools may play a particularly important role in identifying and responding to children's mental health needs. Youth spend more waking hours at school than they do at home, which means that school counselors, faculty, and staff at schools may play a particularly unique role in helping to identify these issues either early or when they occur. Schools are the most common institutional entry point to mental health services for adolescents, and oftentimes they connect them to community-based services. And this means that about half of adolescents who receive mental health services in the US in a year access them in an educational setting, either alone or in tandem with community-based health services. So schools fill a gap in the treatment landscape for adolescents and may potentially play an important role in addressing not only these mental health conditions, but also follow-on educational issues such as disciplinary problems, chronic absences, dropout, and then later life poor functioning and health as adults. So from a policy perspective, we've taken a couple of approaches to addressing the fact that schools are this unique place that kids can receive not only mental health services, but physical health services. So federal funding to address healthcare needs for students has been predominantly provided via school-based health centers, or I'll refer to them as SBHCs. SBHCs were first, as a model of care, were first launched in the 1960s. They primarily were launched in secondary schools, high schools, in urban areas of the US. In 2010, with the passage of the Affordable Care Act, the number of school-based health centers were boosted because there was specific funding set aside to start to provide additional support via schools with a rate increase with a rate of growth 3 times higher in rural areas versus urban areas. So this has really now become a mechanism by which we might start to fill geographic gaps in rural areas. In 2014, SAMHSA, along with some other federal agencies, awarded very large, upwards of almost $2 million a year grants called AWARE grants. And Tennessee has received three rounds of AWARE funding to support the mental health of students, particularly in distressed areas. And in 2020, the School-Based Health Centers Reauthorization Act extended funding for SBHCs from the ACA through fiscal year 2025. So we have this long history of supporting school-based health in the US. And SBHCs are more than, we should think of them as like more than just a school nurse. They offer comprehensive screening, chronic disease management, and treatment in many cases. And they're required to provide these comprehensive services both for physical health and for mental health. So you think of like hearing, vision, screening tests here, monitoring a healthy weight, providing crisis intervention and mental health assessments. And for rural, low-income, and other historically underserved children, school-based health centers often serve as a medical home. So supporting these via this federal infrastructure is important. The literature often identifies 4 different kinds of school-based health centers. There are telehealth SBHCs, so where a telehealth module is set up in the school and it connects students to a healthcare provider that lives elsewhere. On site, where schools have actual physical clinics inside of them. Mobile, which means that in Tennessee, for instance, we have a mobile van that travels around to several rural counties in West Tennessee and serves multiple schools. And then linked. So this would be an arrangement between a school and an FQHC or a rural health clinic for a portion of that FQHC's patient population or patient panel to be served by students of that school through the school system. So despite the fact that we've had SBHCs around for a long time, 60 some odd years at this point, research on school-based health centers and their effect on child health and education outcomes is really mixed. The literature does find that school-based health centers are associated with declines in dropout rates, declines in teen birth rates, and the development of chronic health conditions in the US. And it also finds that SBHCs are associated with increased test scores and students reporting that they have a usual source of medical care. The evidence is mixed or inconclusive on outcomes such as school attendance, self-reported mental health, and high school completion. Much of this work has not been focused on child's mental health outcomes, but rather the bulk of it has been focused on physical health outcomes, and very few studies use longitudinal long-term data with baseline information of what was happening prior to the SBHC being implemented. And there's often not a comparison group to say, is this just broad improvements in the healthcare landscape or in mental health outcomes for kids, or is this really being driven by what's happening in a school-based health center? So in this work, we ask, how do school-based health centers affect children's mental health outcomes in Tennessee? Tennessee is a unique context to study this, not only because we have this really cool data set I'm about to tell you about, but also because Tennessee is one of the state, it has a suicide, an adolescent youth suicide rate higher than the national average. We have very diverse populations, both in terms of geography, but in terms of racial ethnic composition. And we're a state, as evidenced by our receipt of AWARE grants, that lacks capacity to provide these services in the community and many of the more rural areas in the state. So I'll now turn to the details of this study. So I'll start with our data source. We have this really cool data resource that we've had in our department or here at Vanderbilt since roughly 2018. And they're longitudinally linked health and education outcomes from 2006 to 2021 for Tennessee children. So my colleagues over in the Peabody School of Education and Human Development have set up this Tennessee Education Research Alliance, which has comprehensive education outcome data on all students enrolled in a Tennessee public school going back to 2006. And here in the Department of Health Policy, in the School of Medicine, we have Medicaid claims data going back for longer than that. And so what we have done is we have linked these two data sets together from 2006 onward. And it gives us the ability to track students in both healthcare systems, in both systems, the health and the education systems over time, to be able to see how health and education system outcomes co-occur for Tennessee students. We've devised a handful of outcomes in this data set, including chronic absenteeism. We have standardized test scores. We have disciplinary infractions and actions and things like grade progression. And then from the claims data, we have all of the things that you can think of we'd normally get from Medicaid claims data. And we can estimate the prevalence of mental health conditions, suicidal thoughts and behaviors, various physical health conditions, and we can also observe healthcare utilization. And importantly, the sample of linked students that match between the health and the education data includes about roughly 70% of children enrolled in a Tennessee public school each year, and about 70% of students enrolled in Medicaid, or children enrolled in Tennessee's Medicaid program each year. You might wonder / worry that students who are not linked in this data set are somewhat different, and then we're either missing we could potentially be missing students who are the worst off if they're not in these settings at all, and we're not able to link them. But when we examine differences between students who can be linked to their education data and students who aren't linked to the education data or Medicaid data, vice versa, we find that in general, they look like the overall Tennessee school age population with a handful of caveats. One is that the proportion of students who identify as non-Hispanic white or Hispanic tends to be slightly higher in the overall school age population. And in our linked data set, because we have one of the stipulations for getting into the linked data set is that you have to be eligible for Medicaid, the students in the linked data set tend to be disproportionately low income, have special education needs compared to the general population of Tennessee students. So using these data, we conduct an embedded mixed methods design, which means that we're going to do some qualitative analysis and then use that qualitative analysis to set the context for the quantitative results that we see. So the first thing we did in this project is, it sounds trivial, but turns out is really not. We constructed a full updated census of all school-based health centers in Tennessee. There are 147 public school districts in Tennessee, and so we got in contact with someone from all 147 districts and asked them if they had a school-based health center. And for the ones that replied that they did have a school-based health center, we then conducted semi-structured interviews and site visits to understand what the resources that they had on hand were, how their school-based health center operates, how it's funded, what kind of services do they provide. And then we purposefully sampled districts without school-based health centers to make them look like districts with school-based health centers, and conducted interviews and site visits in these districts because it is possible that these school districts say they don't have a school-based health center in them, but actually do provide services that seem that are like the same kind of services a school-based health center might have. We focus primarily on mental health service infrastructure and funding sources. And then we took these data and applied them to a quantitative approach. So we first, and what I'm going to do today, is describe trends in child mental health outcomes and healthcare use in Tennessee. And then I'm going to use some temporal variation in the implementation or rollout of school-based health centers across Tennessee from 2008 to 2009 to estimate changes in children's outcomes before and after an SBHC is adopted, comparing them to students who are in school districts that do not have an SBHC. I'm going to do this with a stacked difference in difference estimator with SBHC adoption measured at the district level. We're going to look 2 years prior to adoption and 5 years after adoption. And because I love a methodological detour, for those of you who aren't familiar with a stacked difference in differences estimator, let me intuitively explain what's happening here. So let's take this fictional scenario where we have 11 school districts implementing a school-based health center over time. 4 of those districts implement an SBHC in 2008, 2 in 2010, 2 in 2014, and 1 in 2016. If we were to just apply a standard difference in differences estimator, like a two-way fixed effects model to this, we might be worried that the observations sort of at the beginning and the end of this time series are unduly weighting our overall treatment effect and biasing it in some way that we can't observe. So instead of doing your regular diff and diff model, what we will do is something that's stacked. And in a stacked model, I'm going to take, in 2010, for each of these various time points that SBHCs are implemented, I'm going to take one of them and I'm going to construct comparison groups. Here, the comparison groups are school districts that never implement a school-based health center. So in 2010, for instance, you have, for District G, you have EI and onwards as comparisons for G and for K. You've got all of these various school districts that don't implement an SBHC as their comparison groups. And I construct a set of comparison districts for each of these set groups of districts that do implement an SBHC over time. So we're going to call this sub-experiment 2. And in sub-experiment 2, we're going to look at what happens to student outcomes from 2008, 2 years before an SBHC is adopted, to 2015, 5 years after an SBHC is adopted. We're going to do this for all 4 of these sub-experiments that I have here, where we line up the years of data that are correlated with the implementation date of each of these school-based health centers. And then what a stacked difference in difference estimator will do is it will then go in and appropriately weight each of these sub-experiments based on how many treated units are in that sub-experiment. So in this case, sub-experiment number 1 with districts A, B, F, and L gets the most weight because there are 4 school districts that implement an SBHC here. While sub-experiment 4, which only has 1 district implementing a school-based health center, gets the lowest weight in this set of in this fictional set of districts and SBHCs. We then take these weights and combine them all together. So we're estimating an ATT, or an average treatment on the treated. We're estimating some effect for each of these sub-experiments. Then we weight that effect based on the number of districts in each sub-experiment, and we put them all together to come up with an overall treatment or effect, an overall treatment on the treated, a treatment effect of what happens when all of these SBHCs are implemented overall. Okay, so methods detour concluded. Before I dive into the results, this work, like all quasi-experimental work, has some limitations. One is that even though the students that are linked mostly look like students that are unlinked. There may not be generalizability to settings that have higher proportions of Hispanic or immigrant children. This may not generalize to other states. So generalizability is a concern. Difference in differences, regardless of what fancy estimator you use, always has untestable causal assumptions. And that untestable causal assumption here is that districts with SBHCs would have looked like districts without SBHCs if an SBHC had not been implemented. And the final limitation is that these are intent to treat estimates, meaning that I'm not actually going to look at the students who receive services from an SBHC. I'm only going to look at the effect overall for all of the children in a district when a district implements an SBHC. So I'm not going to be looking specifically at the children who end up getting those services or the children who have the SBHC like linked to their school. I'm going to be doing this at the district level because that's where we measured SBHC adoption. Okay, on to the fun part. So remember the first step in this was to conduct a census of all school-based health centers in Tennessee. So we started with publicly available lists from the Tennessee Department of Education and the School-Based Health Alliance on where they think SBHCs exist based on their surveys of school districts in Tennessee. From there, we contacted, those lists didn't overlap, so we decided that maybe we needed to do our own. From there, we contacted the coordinated school health director in each district. And of the 147 districts in Tennessee, we've been able to confirm the district's SBHC status in, I think actually this number is up to like 144 now, 142, most of them. And based on the census, we have confirmed that there are 54 school-based health centers in Tennessee. They are these yellow dots here. 23 of these started in 2020 or later, and so we're actually not going to be able to look at them in this particular analysis. And 54 SVHCs that we learned of have closed. We'll talk about that at the end, and no longer offer services to students. You can see that there's like pretty wide variation across the state of Tennessee as to where these SBHCs are located, and predominantly they're located in more rural areas. So this here is where the Appalachian Mountains run through Tennessee, and this particular part of West Tennessee is also fairly rural. The big cities in Tennessee are here, Memphis, Nashville, and then Knoxville over here. Early on, it was the large urban districts in Tennessee that adopted school-based health centers. So in this graph on the x-axis is the year, the academic year, and on the y-axis is the number of school districts that adopt an SBHC. And then the numbers that sit on top of each bar are the number of schools in Tennessee represented by the districts that implemented an SBHC. So you can see that these here are pretty big districts that implemented school-based health centers given the relative number of schools. But as we get further out in time, we see smaller districts adopting an SBHC model in later years, where we have lots of districts but very few schools. These are much smaller districts. Now I'm going to move on to describing some trends in mental health conditions and healthcare use among Tennessee students. So these are for students who are linked in our health and education data set and are between the ages of 5 and 18. What we see is that similar to national trends, mental health diagnoses in Tennessee have increased over time, and older students, as we might expect, have higher rates than younger students. The yellow line is all students here, and then each of the dashed lines is older students are students by age, and this line here is the oldest students between 4 and 17. And by the end of our study period, approximately 12% of students in Tennessee have a diagnosed health condition. So this is from claims diagnoses. So the prevalence, if you were to implement a screener, is likely higher, but these are the kids who show up in healthcare claims. These are primarily driven by the rates of diagnosed ADHD, anxiety, and depression. Overall rates of ADHD diagnosis in Tennessee are growing, and they end up at about 8%, and it's the largest diagnosis in the state. But you can also see that even pre-COVID-19 pandemic, we see increases in rates of diagnosed anxiety and depression among school-age children in Tennessee. There is, as the rate of school-based health centers grow in Tennessee, there's a considerable increase in the proportion of students, percent of students who receive care in a school-based setting. So before 2012, it's less than 2% of students receive care, any kind of care in a school-based setting. And then by the end of our study period, it's roughly 10% of students. If you were to extend this out into COVID, this like drops precipitously because kids weren't in school in 2020 to have school-based health services, but it starts to tick up as kids return to school post COVID-19. Additionally, we find that rates of ED visits for mental health conditions are increasing over time. So this is all mental health visit, but these are all behavioral health conditions. The rate of ED visits, the percent of students who have an ED visit for a mental health condition grows like almost fourfold from 2006 to 2018. And then you see large relative increases in ED visits for substance use and suicidal ideation, self-harm later in the study period. We find in general that medications are the most common type of treatment for mental health conditions among Tennessee students. And that increases a little bit over the study period. You can see that telehealth is increasing later in the period, but still represents a relatively small proportion of treatment for students in Tennessee. And then the rate of any mental health outpatient visit sort of hovers between 8 and 10%. I should also note here that this is not conditional on having a mental health diagnosis, but they are visits that have some mental health code associated with them. Students with access to an SBHC are different than students who don't have access to an SBHC over our study period. So this is in 2000, this represents data from 2007. So this is before any school-based health center in our study is implemented or adopted. And this is for all, this is among the categorization of with or without an SBHC is over the entire study period. So it's not those who just adopt in 2008, it's those who end up adopting by 2019. You can see that the proportion of students who are female is approximately the same across those with and without an SBHC. But as we saw early, the districts that adopt early are larger urban districts. And you can see that the proportion of students who identify as Black is much higher in districts with SBHCs than without, which suggests that SBHCs may be targeting underserved communities by the community-based healthcare system. And then districts with an SBHC tend to have higher proportions of students who are low income, again, meaning that SBHCs are likely targeted to places that are underserved. by the community-based health system. Okay, so I'm now going to dive into my difference and differences estimates from that stacked diff and diff estimator I showed you a few slides ago. We're going to start with the outcomes that are related to diagnoses. And let me orient you here. So these are the results from ordinary least squares regression. So they're percentage point changes in the prevalence of the condition. On the x-axis here is going to be what kind of mental health condition we're looking at, the prevalence. The y-axis. The x-axis is going to be the percentage point change in the prevalence of the condition. The dots are the coefficients on the difference in differences estimator, or the treatment effect we care about. And then the lines represent 95% confidence intervals. Results are statistically significant from 0 if their confidence intervals don't cross this dotted line right here. So what we find is that the adoption of an SBHC is associated with a 0.75 percentage point reduction in the rate of diagnosed mental health conditions compared to districts without an SBHC. And this is primarily driven by reductions in the diagnosis of ADHD, though reductions in anxiety and depression are similar. So 0.75 percentage point decreases may not seem like a lot. And in fact, these are just over 0.4 percentage point declines in the prevalence. But when we look at them on top of baseline rates, we find that the relative declines are quite substantial. So this is a relative decline of 9% in the diagnosis of ADHD, 10% for any mental health condition overall. And then for anxiety, this represents a 42% relative reduction in the prevalence of anxiety post-SBHC adoption. There are two primary mechanisms by which this could be affecting diagnoses. And it's really important in order to understand the benefit of an SBHC, what mechanism is at work here. So it could be that school-based health centers are operating in primary prevention. They're implementing universal prevention programs that allow students to talk about to understand their feelings, to understand their emotions, which may reduce the symptomology of mental health and prevent a student from ending up at a clinical level of having a diagnosable condition. It could operate on secondary prevention, meaning that students are identified as having a mental health condition and then referred to treatment, and we see declines over time. But it also could be a mechanism of substitution, whereby school-based health centers aren't billing Medicaid. So students who end up gaining access to a school-based health center, the prevalence of mental health conditions may not change, but what we can see in claims changes because students stop going to community-based providers for these mental health treatment services and instead are getting all of the care they need from an SBHC that doesn't show up in Medicaid claims. So what we're going to do is use our healthcare utilization or use results to try and tease out which of these mechanisms we believe an SBHC is probably operating through. Outcomes overall make it very murky, or outcomes only make it very murky to decide if this is a primary prevention story and SBHCs are doing what they intend to do, or if this is a substitution story and what is happening is we just can't see changes we can no longer see these students in our Medicaid claims. Marianne, do I need to pay attention to the chat?
Sorry about that. No,
Oh,
I
no, you're
have
good.
the questions here. We have a couple of questions, but um, uh, do where
Ah,
where are you in the presentation?
great.
Do we want to
No,
let
I'm
you
not done, so
finish?
I'll
Okay.
just keep going. Perfect. Okay. I just want to make sure they weren't clarifying questions. Thank you. Okay, so moving on to healthcare use, what we also see differential changes in healthcare use after the implementation of an SBHC. We see relative increases in a school-based visit. That's approximately 1 percentage point increase. We also see increases in outpatient mental health visits. We see statistically significant declines in telehealth mental health visits, um, mental health prescriptions or prescriptions for medications that treat mental health conditions, and then in ED visits for mental health substance use disorder. We don't see any statistically significant change in the use of psychotherapy visits or in ED visits for suicidality. These are relative reductions of 12% for relative increases of 12% for outpatient mental health visits, and then relative reductions of 9.4 and 25% for mental health prescriptions and ED visits, respectively. So we can use these healthcare utilization results to inform what the mechanism through which SVHCs are operating on the diagnosis of mental health conditions. When we look at primary prevention as a potential mechanism that SVHCs are working through, we see what I would call strong evidence that primary prevention is a mechanism through which SVHCs are working by looking at the statistically significant decreases in ED visits for mental health, and the statistically significant decreases in mental health medication use, right? If this were just a substitution effect, nothing was happening to the diagnosis of these conditions other than they aren't showing up in Medicaid claims. We wouldn't expect to see reductions in receipt of acute services for these conditions. And we also wouldn't expect to see reductions in medication use. It could also be a secondary prevention story that this wouldn't operate on diagnosis, perhaps, but maybe it is also that school-based health centers are doing a very good job of connecting students to community-based resources, and so we don't, there's no change in diagnosis. That's not what we see in diagnosis, but like there could also be that they're connecting students to community-based resources and acting as secondary prevention mechanism. So we find evidence for secondary prevention through the increased number of outpatient mental health visits, right? So it seems like not only are students using high acuity services less, but they're also using lower acuity or community-based services more. And we also see an increase in school-based visits. So if schools weren't billing Medicaid at all after the adoption of a school-based health center, we wouldn't see any change in school-based visits, but we do see some change in school-based visits after the adoption of an SBHC. We also see some effects that suggest that there might be some substitution going on. The reduction in telehealth visits suggests that maybe these services are just being provided in schools and not billed via Medicaid. This is likely happening later in our study period, where we see an increase in telehealth use in school-based health centers in our qualitative data. And so this is likely happening in the later, and it could be substitution that's driving some of the reductions in diagnosis. In general, where we sort of land on the mechanism of an SBHC is that it's probably some combination of all of the things that we see in our claims data. It does, and then combined with our qualitative data, it does seem like schools are doing a lot to help students understand their feelings, to manage their feelings, and are keeping them from reaching a clinical level of symptomology via the things that they're doing, the universal prevention, and even some of the secondary prevention things that they're doing in school-based health centers. We also know that school-based health centers can't meet all of the needs of the students, and they are connecting them to outpatient care. And we also know from our, as I already said, from our interviews that there is likely some substitution happening where there are some school-based health centers that aren't billing Medicaid because it turns out is like a pretty cumbersome process, and are instead choosing to use the money dedicated for school-based health centers to either hire staff in-house or to link with other healthcare providers who may or may not bill Medicaid. Schools and school-based health centers face considerable challenges. And I wrote this slide early in 2025. The challenges that they face moving forward are likely even greater. Most of the school-based health centers in Tennessee cobbled together funding from multiple sources, grants, some state funds, some state education funds, but they all lack reliable long-term funding sources, and what we heard from them is that they're always scrambling to figure out how they're going to continue this program moving forward. Reliable long-term funding for SBHCs would allow them to focus on the things that they are put there to do, which is to provide high-quality, comprehensive health care services to students. SBHCs also talk about how obtaining parental consent is an issue in Tennessee, and this is likely to continue as an increasing number of states pass parental consent laws for the treatment of any health condition among minors, including even talking to a therapist in school. We know that there are workforce issues among the behavioral health workforce in general, and schools have a particularly hard time filling workforce gaps. And we also heard from schools that space, particularly for on-site SBHCs and for telehealth SBHCs, is a problem. For the telehealth mostly linked, the telehealth SBHCs have a hard time finding a place that is private for students to go to have their telehealth visit that isn't a nurse's office or isn't a broom closet. So this is, and finding adequate space for even the provision of these services on site. We hear from our school-based health centers here in Tennessee is a problem. There have been recent federal policy changes that may make it slightly easier for school-based health centers to find a reliable, consistent source of funding. So in late 2021, early 2022, the federal government passed a law that minimizes the free care rule, or gets rid of the free care rule for school-based health centers, allowing states to cover school-based service, allowing state Medicaid agencies to cover school-based services for all students, regardless of their special education documentation. Before this law was passed, states were told that they could cover these services for everyone, but not very many states did. So we see an increase in the number of states who are covering Medicaid, covering school-based services via their Medicaid program, which may be a source of reliable and consistent funding. Both CMS and Medicaid.gov now have resources and technical assistance centers presumably still have resources and technical assistance centers for schools and Medicaid agencies to understand how they might minimize the burden of Medicaid billing, which is a step in the right direction and points to where I would like to go with this work in the future. As I tried to convince you, Tennessee is a unique, neat place to do this. But there are many states in the US that are doing really cool and innovative things to provide school-based services to their students. So I'd love to expand this work into other states. In general, we don't have a great sense broadly of the kinds of healthcare services that schools provide. So I've shown you diagnoses of prevalence of health conditions and kinds of healthcare utilization in Tennessee, but those visits are happening not just in schools, but also in the community. And I think understanding what schools feel equipped to provide is really important as we think about bolstering their role in the continuum of care for children. And then, as I alluded to a second ago, there have been changes in federal policy around Medicaid's free care rule, specifically for school-based health services. And so I'm hoping to find the opportunity to do some quasi-experimental work across states and examine changes in child mental health outcomes as a result of this rule change. So I will stop there with some acknowledgments of the people who helped this research be possible, including our research practice partners, my co-authors, and our funding source. And I think I'll open it up to questions.
Thank you, Dr. Fry. That was really interesting, and Tennessee sounds fascinating. We do have 3 questions, so I'll see if we can get through these. If school-based healthcare centers are concentrated among lower-income students, and if there have been disproportionate reductions in ED visits for low-income students versus the wealthier populations, which is what we find in Illinois, then may this be selection bias in your results? So could your results be reflecting selection bias?
Yeah, that's a great question. So because potentially there would need to be some selection bias. Uh, we know in Tennessee that places that are of greater need are implementing school-based health centers in those places. But the general trajectory is overall in all students in Tennessee is that these health conditions are worsening, right? The trends I showed you aren't just from students with school-based health centers. Those are all Tennessee students. And so to see any disproportionate decline in these conditions suggests that they probably are working in some way, and this isn't just regression to the mean or sort of lopping off the tail end. But I also think that that's where we want to be targeting these resources. And if they're doing anything on the margins, then it's probably worth continuing to provide these services in schools.
Great. Our next question is, and I think you've addressed this a bit, but I'd like to hear more on it. Will recent major policy changes, such as Medicaid cuts, affect the need or capacity of the school-based health centers?
Thanks, Dr. Allen. It is entirely possible for that question. It is entirely possible. State Medicaid agencies are likely going to be facing some really hard decisions around the services that they provide writ large, given cuts to provider taxes, the infrastructure requirements of implementing things like community engagement or work requirements. And so it's entirely possible that Medicaid changes coming down the pipe are going to affect the capacity and the ability of schools to continue providing the services that they provide. that coupled with, likely ongoing workforce issues are going to make it hard for schools um, to meet the needs of students who have mental health conditions.
Thank you. Um, and here's our last question we have up. It's a sort of comment and question. So Tennessee's doing fantastic work using funds to create the initial infrastructure for long-term sustainability um, outside of funding needs. However, is it possible, because of the complex billing process to bill Medicaid, that not billing government insurance can change the narrative of need due to a decrease or not sufficient claims for certain age groups? Interesting.
I'm just reading the TLDR to make sure that I'm understanding this question correctly. Um, could, possible. I mean, I guess it's possible. Um, although I guess it's possible that SBHC is doing such great work means that fewer kids are showing up to receive mental health visits in the community for mental health reasons in the emergency department, and thus a vac create the appearance of there not being a real problem or that Medicaid is not needed. Um, there are I do think increasingly, given what's going on at the federal level with both Medicaid and the Department of Education, like we haven't even touched that behemoth of what's happening at the federal level there. I do think that school-based health centers in a lot of states are going to have to try and figure out Medicaid billing, even if it's like super complex. Um, and I'm not sure that they're going to be able to like continue this kind of this kind of infrastructure and support outside of something like billing Medicaid uh, moving forward. So
Yeah,
in
great,
theory, it's
great.
possible. In theory, it's possible. I'm not sure it's the direction we're heading.
Thank you. I think, these questions just underlie how complicated this equation is. We have one last question, which we have time for, which is from Neil Jordan. Appreciate your work in this area. To what extent do you understand the variation in school-based healthcare centers across districts and schools in how the variation actual delivery of mental health care impacts outcomes?
Um, that is a great question, and that is work that we have underway right now. So from our surveys or interviews of school-based health systems, we know a lot about how they're delivering mental health services, whether they're um, bringing in their own staff to provide those services, linking with people who are funded by like the Tennessee Department of Mental Health and Substance Abuse Services, and work for the big behavioral health agencies, whether they're contracting with an FQHC or whether or not these services are provided in-house versus telehealth. So we're working on that paper and that evidence right now. We know there's variation in how these services are delivered. We suspect there's probably variation in the quality of services delivered. So we're digging into that right now. So stay tuned for um, those results coming to a journal near you.
I think we have a lot to stay tuned for here. Certainly a lot of great work emerging. On behalf of IFAM and the Bueller Center, I want to thank you for this, sharing your work with us and this thought-provoking work. And thanks everyone for attending. And everybody have a great day. Take care.
Thanks.